The next session is on the incidental pituitary lesion by Dr. Nitin Kapoor. Dr. Nitin Kapoor completed his DM and postdoctoral fellowship training in endocrinology at CMC Vellore. He has been conferred with Tamil Nadu Dr. MGR University Gold Medal in endocrinology in 2015. He had more than 75 scientific papers in national and international journals, and his area of interest are obesity, metabolic syndrome, pituitary disorders, and metabolic bone disorders. He is the editor of 8th edition of the book A Practical Guide to Diabetes Mellitus, released in April 2018. I repeat, the topic is on the incidental pituitary lesion. The incidence of incidental pituitary lesion is increasing nowadays with the availability of more widespread MRI. So we see more patients coming with an MRI showing that, sir, I'm having a lesion, what to do? How to investigate, how much endocrinologically to investigate, how much neurologically to investigate, what to do. We'll hear from Dr. Nitin Kapoor.
Thank you, Chairpersons. Right at the onset, I'd like to thank the organizers, Dr. Prem, Dr. Shakti, and the entire organizing team for inviting me and hosting such a splendid conference with such a large audience. Over the next 20 minutes, I will take you through this topic as to how to manage or approach a patient with an incidental pituitary lesion. I think in clinical medicine, many times we deal with incidental lesions, and many of them which are incidentally detected are often underestimated just because of the virtue of the fact that they have been found as an innocent bystander when we're actually looking for something else. But that may not be always true when we're talking of incidental lesions in the pituitary. Classically, a pituitary incidentaloma is defined when you have an unsuspected cellular mass which has been picked up on imaging like a CT or an MRI, which has been done for a patient in which you did not suspect a pituitary disease. I think when you have a patient which is sitting in front of you, it is a great matter of concern for him because this patient has a diagnosis of so-called as a brain tumor. This patient, with all the advent of media, Google, and all this knowledge that the patient gets, is really worried. The patient will come and ask you whether, doctor, this will affect my lifespan, whether this will be benign or malignant, is this cancerous, and so many questions. There's a lot of stress in the patient's mind when they come with this diagnosis of a pituitary incidentaloma. From a physician perspective, this is a patient which can come into the emergency with life-threatening emergencies like pituitary apoplexy, severe hypoadrenal crisis. As a physician, we also need to be aware that these are the patients who may have pituitary dysfunction, hypopituitarism, or even hyper-functioning pituitary tumors. It's a pity that in today's world we have an MRI first and then we clinically look at a patient and diagnose to have hypopituitarism or hyperpituitarism. And last but not the least, as physicians, again, we should be aware of certain conditions in which the pituitary may be actually hyperplastic, but it's not an adenoma. And these are conditions like pregnancy, physiological conditions like pregnancy, puberty, or sometimes even pathological conditions like severe primary hypothyroidism, wherein the pituitary gland may become hyperplastic. But once you manage the primary condition, this will get back to normal. So definitely, dealing pituitary incidentalomas is a matter of great importance for both the patient and the physician. Let's begin with a case. This is the story of a 51-year-old gentleman who presented to the emergency department with history of headache and transient loss of consciousness after an alcohol binge. I think it's a very common scenario in any government emergency that we see across the country. This patient had no previous known comorbidities. His pulse rate was about 68, blood pressure was normal, and no clinically any neurodeficits were formed. The CMO sitting there in the casualty said, let's do a CT brain to rule out subarachnoid hemorrhage because this patient had so-called some transient loss of consciousness. Well, the CT is done. The CT did not show any subarachnoid hemorrhage, but there's a large pituitary cellular lesion which is sitting there. And this patient is referred to you as a physician after doing an MRI scan of the pituitary for further management. The MRI is done, and that shows a large cellular mass, a pituitary macroadenoma, which is slightly invading the left cavernous sinus, compressing the optic chiasm. It's more than 10 millimeters, so it's a pituitary macroadenoma. What next? So this patient comes back to you, sitting in front of your OPD, and then we need to manage it. The first question that we need to answer is, how common are actually such lesions? And how commonly are we expecting such patients to walk into our OPD? When you talk of history of pituitary disorders, way back in 1920, it was Harvey Cushing who actually first described a lot of pituitary disorders, but at that time there was no MRI and CT scan. But even at that time, when there were post-mortem studies, it was found that a lot of these patients had pituitary lesions which they had never talked about in their life. And these were so-called subclinical adenomas of the pituitary gland during that time, and still they were very common. Even if way back in 1930s, they were about 8.4%. Today, now that we have MRI and CT scans and we look at how many normal people who undergo a pituitary imaging and are found to have lesions, the number is quite high, 10%. Just now Shakti announced that there are 1,000 registrations. So 100 of them actually have a pituitary incidentaloma. It's 10% of the normal population. 1 in 10 of us in this room have a pituitary incidentaloma. But there is a difference. Most of them are very small lesions. It's irrespective of whether you're a male or a female. Across all adult age groups, it may be there, but the fact is that these are common. But this is not what we usually see in our clinical practice. And what we see in our clinical practice is very well exemplified in this paper published in the European Journal of Endocrinology about 2 years ago. This is data from an endocrine clinic in the Middle East, and they looked at about 330 patients of pituitary incidentalomas, and what they find is that 73% of these patients actually have a pituitary adenoma, of which the most common reason as to why they underwent an imaging is headache, and most of these adenomas are actually macroadenomas. So this is not what 10% I was talking about. Most of these patients which are actually referred to our clinic have pituitary adenomas. Most of them are macroadenomas. What more, when we look at the pituitary function of these patients, about 25% of them actually have functioning tumors. It's very strange that clinically we diagnose these functioning tumors after an MRI. And about a third of them have hypopituitarism. And that treating hypopituitarism in these patients is very gratifying because the quality of the life of that patient would improve remarkably. Overall, about a third of these patients who actually entered this endocrine clinic, a total of 300 patients, about a third of them actually warranted surgery. So definitely this is a big problem when you manage patients with pituitary adenoma in your clinic. When you try and decipher what is the cause of pituitary incidentalomas in your practice, about a large proportion of them are actually non-functional adenomas, about 55% of them. Another 20% of them are functional adenomas, again most common being growth hormone and prolactin secreting tumors, and the remaining are either cystic lesions or could be meningiomas or could be craniopharyngiomas. But by and large, the majority, about 70% of the patients that you see with pituitary incidentalomas actually have a pituitary adenoma. And as I mentioned before, about 3/4 of them are actually macroadenomas. So definitely this is a matter of concern. There's another Japanese study that I would show, which has actually followed up patients with pituitary adenomas over a period of 5 years. And what they found was that about 20%, that is 1 in 5 pituitary incidentalomas who have adenomas, actually the lesion grows in size. So far we are clear. Pituitary incidentalomas are common. About a third of them have hypopituitarism. About a fourth of them may have hyperfunctioning pituitary hormones, some of them subclinically. Again, 30% of them require surgery. So definitely this is an important topic that we all should be aware of. So once we have this patient who is sitting in front of us and with an MRI scan which is showing a pituitary lesion, how do we evaluate them? What are the important points in history and examination that we need to ask? What are the important biochemical investigations, whether they're hormonal investigations or non-hormonal investigations, what do we ask for? And which are the other specialties that we need to call upon? Do we send a referral to the ophthalmologist, to the neurosurgeon, and sometimes even to the radiotherapist? So let's look at that. The first and the most important thing is taking good clinical history. And as I mentioned before, a large proportion of these are pituitary adenomas, among which, again, 70% are macroadenomas. So symptoms like headache, symptoms of visual disturbance, symptoms because of pituitary stalk dysfunction, which may cause hypopituitarism, sometimes invasion of the cavernous sinus causing symptoms, and symptoms of hypopituitarism may happen. But remember, these are patients who are incidentalomas, so they never thought of these symptoms any time before. But now when you retrospectively ask them, they may have these symptoms. Why do they have headache? For the students in this hall, I think we're taught in physiology that there are certain pain-sensitive and pain-insensitive areas in the brain. And one of them is the dura. Dura is a pain-sensitive area. And we know that the pituitary is covered very nicely with the diaphragma cellae, which is a pain-sensitive region. And when there is a lesion in the pituitary and there's stretching of the diaphragma cellae, that is indeed one of the most common causes why they develop headache. The other important history that you need to ask is about visual complaints. It's not very easy in clinical practice to try and find out about visual complaints, but what is classically taught is it's about bitemporal hemianopia. I don't think so. I've had a patient who comes and tells me that I have bitemporal hemianopia. The indirect ways of asking this question, the patient would say when they walk on a narrow corridor, they may bang on the walls, or when they're crossing a road, and rather than seeing a bus from a distance, the bus suddenly comes in front of them. But these are subtle questions that the patient may sometimes be able to tell you. The other important visual complaints that you need to ask is about loss of visual acuity, how the vision has been affected, and because of optic atrophy, one of the early symptoms that these patients may have is loss of color vision. Apart from this, it's important to find out history of hypopituitarism, and the common order that is followed, which is because of any pituitary tumor, is the growth hormone deficiency, which happens first, which again in adults can be very subtle. What is earlier seen in women is menstrual irregularities, amenorrhea, in men erectile dysfunction, followed by affection of the cortisol and the thyroid axis. As I mentioned before, about 30% of patients with pituitary incidentalomas can have hypopituitarism. When you talk of hyper-functioning pituitary adenomas, there are about 25% of pituitary incidentalomas which may have excessive hormones, the most common ones being growth hormone and prolactin-secreting hormones. However, we must remember that some of these clinical manifestations are very subtle, and it is still very sad. Sometimes we've had even florid Cushing's and acromegaly who've just had an MRI done for headache, and then retrospectively the patients have been evaluated for these hyperhormonal secretions, these medical conditions which we are taught. As a medical student, today we first do an MRI and then go on to clinically examine them. So by and large, these symptoms of pituitary incidentalomas may be very subtle, and we need to spend good time in history and examination to try and find out these symptoms and then evaluate the patient further. Well, these are not the only points in history that we need to ask. If you have a young patient with pituitary incidentaloma, then you also need to make sure that you ask relevant history for any syndromic assessment, especially syndromes like MEN1, wherein you would like to ask, did anybody in your family had renal stones? Did anybody had recurrent fractures? Did you have recurrent fractures? Did you have anybody in your family who had tumors in the abdomen? And these kind of symptoms. We recently had a patient who presented to us with ataxia. This is a patient with MEN1, which was diagnosed quite late in the process of disease. This patient had ataxia, and so he went to the neurologist, and he had altered behavior, which was going on for 5 years. The neurologist did an MRI scan, which showed cerebellar atrophy, but it also picked up a pituitary lesion. It was later found out that this patient actually had also insulin-dependent hypoglycemia and hyperparathyroidism. The ataxia and the cerebellar atrophy was because of undiagnosed prolonged hypoglycemia. But this was a pituitary incidentaloma, which actually led up to the diagnosis of MEN1, which was genetically proven. So once we are through with our history and examination and syndromic assessment clinically, we move on to biochemical investigations. There could be hormonal investigations that we would want. And the two most important things, which are often life-saving, is 8 cortisol and thyroid function tests. Yes, you would like to do other hormones like to assess the gonadal axis, the growth hormone, and IGF-1 only if there is clinical suspicion. Assessment of 8 cortisol, that is the first test that you would like to send, is like in any other hormonal dysfunction, wherein if the value is very low, you're sure that this patient has hormonal deficiency. If the values are high, then you need to consider Cushing's. If the values are in the middle, then you probably want to do an ACTH stimulation test. How do you suspect Cushing's? Ideally, again, as in a usual process, even in patients with pituitary incidentalomas, we'd like to do 2 or 3 screening tests. At least 2 should be positive. Even though these patients have been absolutely asymptomatic, sometimes you don't want, or the patient doesn't want to take so many tests just because you have to rule out Cushing's. So something simpler, probably what we saw, was to just do a spot urine cortisol creatinine ratio, which was found to have a good sensitivity and a specificity in practice. It's something like a urine protein creatinine ratio, wherein a morning sample of cortisol may be able to predict nicely whether the patient needs further evaluation or not. It's also important to rule out thyroid dysfunction in these patients, especially hypothyroidism. And the only point that I'd like to stress here is, please don't only ask for TSH. It's important to assess T4 and free T4 in patients with secondary hypothyroidism. Like in this particular case, the TSH may be actually within the normal range, but this TSH is actually much less or inappropriately low for the amount of T4 that is there. I know that classical teaching says that whenever there is secondary hypothyroidism, there will be low TSH, low T4, low free T4. But in this patient, the TSH is actually inappropriately low to the level of low T4, and this is secondary hypothyroidism. So only asking for TSH doesn't help. Even monitoring therapy sometimes, we've seen patients just checked with their TSH, and if the TSH is low, the dose is decreased. Please remember, when you're dealing with a pituitary tumor, we need to do T4 and pre-T4 as well, and TSH alone does not suffice. So sometimes there could be hyperthyroidism as well. This is a rare patient wherein the T4 and the TSH is elevated, but it's unlikely that this patient would be only incidentally detected. The third important hormone that we assess is prolactin, and it's important to remember again here that every elevated prolactin is just not a prolactinoma. It may be just because of the compression of the stalk, wherein dopamine, which is an inhibitory hormone for prolactin in the pituitary gland, if that is compressed because of an incidental pituitary tumor, then these people can have mildly elevated prolactin. If the prolactin levels are very high, then only you would suspect a prolactinoma. It's also important to assess hypogonadism. It's easier in women because they have their alteration in menstrual cycles earlier, but assessing testosterone, LH, FSH in men can also give us that diagnosis. Talking about gonadotropin secreting pituitary adenomas, they may have either increased LH, FSH, or maybe having just increased alpha subunit. So these are the usual hormones that we would check for any pituitary adenoma. It's nothing specific for pituitary incidentalomas. But what you also need to remember is that there are certain other investigations that you need to do, some which I already mentioned in the form of if you have clinical symptoms of any associated syndromes like MEN1, I would definitely check a fasting calcium, phosphorus, and albumin in all my patients with a pituitary incidentaloma to rule out a possibility of MEN1, especially if the patient has a young onset disease. You've planned for surgery. Many times I'm the only physician who's managing this patient before surgery, and I need to give that clearance before the patient goes to anesthesia. So I better ask for those investigations. As I mentioned, that about 30% of these patients undergo surgery. So I make sure that I do an ECG, a chest X-ray, a simple test like serum electrolytes, which need to be assessed before surgery. If they have functional tumors, then we need to assess the other associated comorbidities like diabetes, hypertension for Cushing's, dyslipidemia, osteoporosis, and so on and so forth. And last but not the least, as somebody mentioned in the last talk, at the end of the day, we are physicians. We cannot say that I'm just going to look at your pituitary incidentaloma and not treat your asthma, hypertension, and other things. So we may ask for those investigations as well. When you refer these patients to the ophthalmologist, it's important you ask specific questions to the ophthalmologist. You just send for an eye referral and you just get vague answers. That doesn't help. The three important things that you would like to learn from an ophthalmologist is how is the visual acuity, so that after surgery, when you see the patient again, has it improved? How is the visual field, whether this patient has bitemporal hemianopia, which is classically described because of stalk compression, and how is the optic disc examination? Does this patient has temporal pallor or not? So these are the specific questions that we ask the ophthalmologist. So far, to summarize, whenever you have a pituitary incidentaloma in your practice, it is essential that you do a detailed clinical history and examination for all these patients. This is from the guidelines of the Endocrine Society in the US, published in 2011. After a detailed clinical history and examination, lab evaluation for hypo and hypersecretion is warranted for all patients, whether it's a macroadenoma or a microadenoma. If the patient has on imaging a lesion which is close to the optic chiasm or the optic nerve, then definitely an ophthalmology consultation is also warranted. And it's only after that that you decide whether this patient will meet an indication for surgery or not. Just before I go on to the indications of surgery, let me show you something about a few differential diagnoses that we need to cover. This is a patient that I saw about a month ago, a 31-year-old gentleman who was referred to me because of this scan which had a pituitary lesion. When I take the history in detail, this patient complains of headache, he complains of weight gain, lethargy, and severe proximal myopathy. And on clinical examination, I had a strong suspicion of hypothyroidism, and when I sent the thyroid function test, we look at a TSH, which is sky high, 255, a low T4 and free T4. So this is an example of thyroid hypertrophy, wherein the pituitary gland, which was diagnosed to be hypertrophied on the MRI, actually has no primary pathology. It's just the TSH hypertrophy there, thyroid hypertrophy there. And once I treat the primary hypothyroidism in this patient, the pituitary gland size will come down. We often get similar referrals even in puberty, even in early pregnancy. Once you ask for a wrong scan, you get a wrong result. So it is important for us to understand that there are physiological and pathological causes which may cause pituitary hypertrophy, which do not warrant any treatment to the pituitary gland, but just treating the primary condition itself would reduce the size of that hypertrophy. Other important imaging characteristics also help us differentiate other causes of pituitary or cellular masses. As I said, that about 70% of them are because of pituitary adenomas, but there are other cellular lesions that may happen, may be detected incidentally. About 10% of them may be cystic, and other lesions like craniopharyngioma or meningioma may also be present. Some of these lesions may have calcification, and in that case maybe a CT scan may help. So calcific lesions of the pituitary would be either a craniopharyngioma, sometimes in meningioma, and even in germinomas. So last, coming up to the treatment of these patients, the first important question when you have finished with your history examination and biochemical evaluation is whether your patient should go for surgery or not. And for that, we should be very clear with the indications of surgery in any patient. The first indication is a visual field defect that may be caused because of a lesion, so you definitely don't want the vision to worsen up. The second important reason could be an acute pituitary apoplexy, which is embarking again on the chiasm and is an emergency again for another surgery. The third important cause would be like in any hypersecreting tumor. When you have a patient with Cushing's disease or acromegaly, then you need to get rid of that tumor, and that would be the best way to get rid of it. There are some relative indications which may depend, again individualized from patient to patient. If the tumor size is increasing rapidly, patient has a lot of headache, patient is planning pregnancy in future, any of these things may be a relative indication. But it's important to remember that these patients with pituitary incidentalomas have not presented to you primarily with any symptom. It's just because somebody has done a scan, and that scan has picked up a pituitary lesion. And now when you offer surgery to these patients and they come back with side effects which you haven't mentioned before, then it's a problem. So please ensure, because these were asymptomatic patients who have a scan diagnosis and later on they develop hypopituitarism, it may be detrimental. So it's important to counsel these patients what are the likely side effects that they are going to expect in their future course. The hormonal treatment in these patients is as similar as in other patients. It's not different. I mean, management of cortisol deficiency would be just replacing physiological doses of prednisolone or hydrocortisone, but it's again important to embark on hydrocort cover for stress, which is important, especially in emergency. It can avoid a life-threatening event. Management of thyroxine deficiency, as I've mentioned before, is important not to target the TSH, it's important to target the T4 and the free T4. In the acute setting, if the patient needs an urgent surgery and if the thyroid functions are like this, then we may use T3. T3 is available as 25 micrograms thrice a day. We give 3 days preoperatively and 2 days post-op, and still the patient can be cleared for surgery. Talking about follow-up of patients who've not had surgery, it would depend whether the patient has a macroadenoma or a microadenoma. For a macroadenoma, I'd like to repeat clinical history, biochemical evaluation, and an MRI scan at 6 months and thereafter every year. If the patient has a microadenoma, then I would like to repeat the investigations after 1 year and then maybe 2 to 3 years thereafter. At every consultation, once the patient comes, I should be having in my mind what were the indications for surgery, does my patient need a warrant or referral to the neurosurgeon. However, the follow-up in all these patients is often lifelong. So to conclude, pituitary incidentalomas is an important problem. It's important not only for the physician, it's important from the patient perspective as well. Most common reasons of pituitary incidentalomas are pituitary adenomas, 55% non-functioning, and about 15 to 20% of functioning adenomas. It's important to have a detailed clinical history and evaluation done in all these patients. And once you have a detailed evaluation done, the important thing is whether your patient will go for surgery or not. And for that, we need to be aware of these absolute and relative indications. And last but not the least, the follow-up of these patients would depend whether it was a macroadenoma or a microadenoma. However, nonetheless, after hormonal treatment, follow-up in these patients is lifelong. Thank you.